3 basic causes of obesity. Psychological aspects. Much has been written about the psychological aspects of obesity. Among its many functions, the diencephalon is also the seat of our primitive animal instincts, and just as in an emergency it can switch energy from one center to another, so it seems to be able to transfer pressure from one instinct to another. Thus, a lonely and unhappy person deprived of all emotional comfort and of all instinct gratification except the stilling of hunger and thirst can use these as outlets for pent-up instinct pressure and so develop obesity. Yet once that has happened, no amount of psychotherapy or analysis, happiness, company, or the gratification of other instincts will correct the condition. Compulsive eating. No end of injustice is done to obese patients by accusing them of compulsive eating, which is a form of diverted sex gratification. Most obese patients do not suffer from compulsive eating, they suffer genuine hunger, real, gnawing, torturing hunger, which has nothing whatever to do with compulsive eating. Even their sudden desire for sweets is merely the result of the experience that sweets, pastries, and alcohol will most rapidly of all foods allay the pangs of hunger. This has nothing to do with diverted instincts. On the other hand, compulsive eating does occur in some obese patients, particularly in girls in their late teens or early 20s. Fortunately, from the obese patient's greater need for food, it comes on in attacks and is never associated with real hunger, a fact which is readily admitted by the patients. They only feel a feral desire to stuff. 2 pounds of chocolates may be devoured in a few minutes, cold, greasy food from the refrigerator, stale bread, leftovers on stacked plates, almost anything edible is crammed down with terrifying speed and ferocity. I have occasionally been able to watch such an attack without the patient's knowledge, and it is a frightening, ugly spectacle to behold, even if one does realize that mechanisms entirely beyond the patient's control are at work. A careful inquiry into what may have brought on such an attack almost invariably reveals that it is preceded by a strong unresolved sex stimulation, the higher centers of the brain having blocked primitive diencephalic instinct gratification. The pressure is then let off through another primitive channel, which is oral gratification. In my experience, the only thing that will cure this condition is uninhibited sex, a therapeutic procedure which is hardly ever feasible, for if it were, the patient would have adopted it without professional prompting, nor would this in any way correct the associated obesity. It would only raise new and often greater problems if used as a therapeutic measure. Patients suffering from real compulsive eating are comparatively rare. In my practice, they constitute about 1 to 2%. Treating them for obesity is a heart-rending job. They do perfectly well between attacks, but a single bout occurring while under treatment may annul several weeks of therapy. Little wonder that such patients become discouraged. In these cases, I have found that psychotherapy may make the patient fully understand the mechanism, but it does nothing to stop it. Perhaps society's growing sexual permissiveness will make compulsive eating even rarer. Whether a patient is really suffering from compulsive eating or not is hard to decide before treatment because many obese patients think that their desire for food, to them unmotivated, is due to compulsive eating, while all the time it is merely a greater need for food. The only way to find out is to treat such patients. Those that suffer from real compulsive eating continue to have such attacks, while those who are not compulsive eaters never get an attack during treatment. Reluctance to lose weight. Some patients are deeply attached to their fat and cannot bear the thought of losing it. If they are intelligent, popular, and successful in spite of their handicap, this is a source of pride. Some fat girls look upon their condition as a safeguard against erotic involvements, of which they are afraid. They work out a pattern of life in which their obesity plays a determining role and then become reluctant to upset this pattern and face a new kind of life which will be entirely different after their figure has become normal and often very attractive. They fear that people will like them, or be jealous, on account of their figure rather than be attracted by their intelligence or character only. Some have a feeling that reducing means giving up an almost cherished and intimate part of them. In many of these cases, psychotherapy can be helpful, as it enables these patients to see the whole situation in the full light of consciousness. An affectionate attachment to abnormal fat is usually seen in patients who became obese in childhood, but this is not necessarily so. In all other cases, the best psychotherapy can do in the usual treatment of obesity is to render the burden of hunger and never-ending dietary restrictions slightly more tolerable. Patients who have successfully established an erotic transfer to their psychiatrist are often better able to bear their suffering as a secret labor of love. There are thus a large number of ways in which obesity can be initiated, though the disorder itself is always due to the same mechanism, an inadequacy of the diencephalic fat center and the laying down of abnormally fixed fat deposits in abnormal places. This means that once obesity has become established, it can no more be cured by eliminating those factors which brought it on than a fire can be extinguished by removing the cause of the conflagration. Thus, a discussion of the various ways in which obesity can become established is useful from a preventative point of view, but it has no bearing on the treatment of the established condition. The elimination of factors which are clearly hastening the course of the disorder may slow down its progress or even halt it, but they can never correct it. Not by weight alone. Weight alone is not a satisfactory criterion by which to judge whether a person is suffering from the disorder we call obesity or not. Every physician is familiar with the sylph-like lady who enters the consulting room and declares emphatically that she is getting horribly fat and wishes to reduce. Many an honest and sympathetic physician at once concludes that he is dealing with a nut. If he is busy, he will give her short shrift, but if he has time, he will weigh her and show her tables to prove that she is actually underweight. I have never yet seen or heard of such a lady being convinced by either procedure. The reason is that in my experience the lady is nearly always right and the doctor wrong. When such a patient is carefully examined, one finds many signs of potential obesity, which is just about to become manifest as overweight. The patient distinctly feels that something is wrong with her, that a subtle change is taking place in her body, and this alarms her. There are a number of signs and symptoms which are characteristic of obesity. In manifest obesity, many and often all these signs and symptoms are present. In latent or just beginning cases, some are always found, and it should be a rule that if two or more of the bodily signs are present, the case must be regarded as one that needs immediate help. Signs and symptoms of obesity. The bodily signs may be divided into such as have developed before puberty, indicating a strong inherited factor, and those which develop at the onset of manifest disorder. Early signs are a disproportionately large size of the two upper front teeth, the first incisor, or a dimple on both sides of the sacral bone just above the buttocks. When the arms are outstretched with the palms upward, the forearms appear sharply angled outward from the upper arms. The same applies to the lower extremities. The patient cannot bring his feet together without the knees overlapping. He is, in fact, knock-kneed. The beginning accumulation of abnormal fat shows as a little pad just below the nape of the neck, colloquially known as the Duchess hump. There is a triangular fatty bulge in front of the armpit when the arm is held against the body. When the skin is stretched by fat rapidly accumulating under it, it may split in the lower layers. When large and fresh, such tears are purple, but later they are transformed into white scar tissue. Such striation, as it is called, commonly occurs on the abdomen of women during pregnancy, but in obesity it is frequently found on the breasts, the hips, and occasionally on the shoulders. In many cases, striation is so fine that the small white lines are only just visible. They are always a sure sign of obesity, and though this may be slight at the time of examination, such patients can usually remember a period in their childhood when they were excessively chubby. Another typical sign is a pad of fat on the insides of the knees, a spot where normal fat reserves are never stored. There may be a fold of skin over the pubic area and another fold may stretch round both sides of the chest, where a loose roll of fat can be picked up between two fingers. In the male, an excessive accumulation of fat in the breasts is always indicative, while in the female the breast is usually, but not necessarily, large. Obviously, excessive fat on the abdomen, the hips, thighs, upper arms, chin, and shoulders are characteristic, and it is important to remember that any number of these signs may be present in persons whose weight is statistically normal, particularly if they are dieting on their own with iron determination. Common clinical symptoms which are indicative only in their association and in the frame of the whole clinical picture are frequent headaches, rheumatic pains without detectable bony abnormality, a feeling of laziness and lethargy, often both physical and mental, and frequently associated with insomnia, the patients saying that all they want is to rest, the frightening feeling of being famished and sometimes weak with hunger 2 to 3 hours after a hearty meal, and an irresistible yearning for sweets and starchy food which often overcomes the patient quite suddenly and is sometimes substituted by a desire for alcohol. Constipation and a spastic or irritable colon are unusually common among the obese, and so are menstrual disorders. Returning once more to our sylph-like lady, we can say that a combination of some of these symptoms with a few of the typical bodily signs is sufficient evidence to take her case seriously. A human figure, male or female, can only be judged in the nude. Any opinion based on the dressed appearance can be quite fantastically wide off the mark, and I feel myself driven to the conclusion that apart from frankly psychotic patients such as cases of anorexia nervosa, a morbid weight fixation does not exist. I have yet to see a patient who continues to complain after the figure has been rendered normal by adequate treatment. The emaciated lady. I remember the case of a lady who was escorted into my consulting room while I was telephoning. She sat down in front of my desk, and when I looked up to greet her I saw the typical picture of advanced emaciation. Her dry skin hung loosely over the bones of her face, her neck was scrawny and collarbones and ribs stuck out from deep hollows. I immediately thought of cancer and decided to which of my colleagues at the hospital I would refer her. Indeed, I felt a little annoyed that my assistant had not explained to her that her case did not fall under my specialty. In answer to my query as to what I could do for her, she replied that she wanted to reduce. I tried to hide my surprise, but she must have noted a fleeting expression, for she smiled and said, "I know that you think I'm mad, but just wait." With that she rose and came round to my side of the desk. Jutting out from a tiny waist she had enormous hips and thighs. By using a technique which will presently be described, the abnormal fat on her hips was transferred to the rest of her body, which had been emaciated by months of very severe dieting. At the end of a treatment lasting 5 weeks, she, a small woman, had lost 8 inches round her hips, while her face looked fresh and florid. The ribs were no longer visible and her weight was the same to the ounce as it had been at the first consultation. Fat but not obese. While a person who is statistically underweight may still be suffering from the disorder which causes obesity, it is also possible for a person to be statistically overweight without suffering from obesity. For such persons weight is no problem, as they can gain or lose at will and experience no difficulty in reducing their caloric intake. They are masters of their weight, which the obese are not. Moreover, their excess fat shows no preference for certain typical regions of the body, as does the fat in all cases of obesity. Thus, the decision whether a borderline case is really suffering from obesity or not cannot be made merely by consulting weight tables. The treatment of obesity. If obesity is always due to one very specific diencephalic deficiency, it follows that the only way to cure it is to correct this deficiency. At first this seemed an utterly hopeless undertaking. The greatest obstacle was that one could hardly hope to correct an inherited trait localized deep inside the brain, and while we did possess a number of drugs whose point of action was believed to be in the diencephalons, none of them had the slightest effect on the fat center. There was not even a pointer showing a direction in which pharmacological research could move to find a drug that had such a specific action. The closest approach were the appetite-reducing drugs, the amphetamines, but these cured nothing. A curious observation. Mulling over this depressing situation, I remembered a rather curious observation made many years ago in India. At that time we knew very little about the function of the diencephalon, and my interest centered round the pituitary gland. Proluk had described cases of extreme obesity and sexual underdevelopment in youth suffering from a new growth of the anterior pituitary lobe, producing what then became known as Frulich's disease. However, it was very soon discovered that the identical syndrome, though running a less fulminating course, was quite common in patients whose pituitary gland was perfectly normal. These are the so-called fat boys with long, slender hands, breasts. Any flat-chested maiden would be proud to possess, large hips, buttocks, and thighs with striation, knock knees and underdeveloped genitals, often with undescended testicles. It also became known that in these cases the sex organs could be developed by giving the patients injections of a substance extracted from the urine of pregnant women, it having been shown that when this substance was injected into sexually immature rats it made them precociously mature. The amount of substance which produced this effect in one rat was called 1 international unit, and the purified extract was accordingly called human chorionic gonadotrophin, whereby chorionic signifies that it is produced in the placenta and gonadotropin that its action is sex gland directed. The usual way of treating fat boys with underdeveloped genitals is to inject several hundred international units twice a week. Human chorionic gonadotrophin, which we shall henceforth simply call HCG, is expensive, and as fat boys are fairly common among Indians, I tried to establish the smallest effective dose. In the course of this study 3 interesting things emerged. The first was that when fresh pregnancy urine from the female ward was given in quantities of about 300 cubic centimeters by retention enema, as good results could be obtained as by injecting the pure substance. The second was that small daily doses appeared to be just as effective as much larger ones given twice a week. Thirdly, and that is the observation that concerns us here, when such patients were given small daily doses they seemed to lose their ravenous appetite, though they neither gained nor lost weight. Strangely enough, however, their shape did change. Though they were not restricted in diet, there was a distinct decrease in the circumference of their hips. Fat on the move. Remembering this, it occurred to me that the change in shape could only be explained by a movement of fat away from abnormal deposits on the hips, and if that were so, there was just a chance that while such fat was in transition it might be available to the body as fuel. This was easy to find out, as in that case, fat on the move would be able to replace food. It should then be possible to keep a fat boy on a severely restricted diet without a feeling of hunger, in spite of a rapid loss of weight. When I tried this in typical cases of Frulich's syndrome, I found that as long as such patients were given small daily doses of HCG they could comfortably go about their usual occupations on a diet of only 500 calories daily and lose an average of about 1 pound per day. It was also perfectly evident that only abnormal fat was being consumed, as there were no signs of any depletion of normal fat. Their skin remained fresh and turgid, and gradually their figures became entirely normal. The daily administration of HCG appeared to have no side effects other than beneficial ones. From this point it was a small step to try the same method in all other forms of obesity. It took a few hundred cases to establish beyond reasonable doubt that the mechanism operates in exactly the same way and seemingly without exception in every case of obesity. I found that, though most patients were treated in the outpatients department, gross dietary errors rarely occurred. On the contrary, most patients complained that the 2 meals of 250 calories each were more than they could manage, as they continually had a feeling of just having had a large meal. Pregnancy and obesity. Once this trail was opened, further observations seemed to fall into line. It is well known that during pregnancy an obese woman can very easily lose weight. She can drastically reduce her diet without feeling hunger or discomfort and lose weight without in any way harming the child in her womb. It is also surprising to what extent a woman can suffer from pregnancy vomiting without coming to any real harm. Pregnancy is an obese woman's one great chance to reduce her excess weight. That she so rarely makes use of this opportunity is due to the erroneous notion, usually fostered by her elder relations, that she now has 2 mouths to feed and must keep up her strength for the coming event. All modern obstetricians know that this is nonsense and that the more superfluous fat is lost, the less difficult will be the confinement, though some still hesitate to prescribe a diet sufficiently low in calories to bring about a drastic reduction. A woman may gain weight during pregnancy, but she never becomes obese in the strict sense of the word. Under the influence of the hCG, which circulates in enormous quantities in her body during pregnancy, her diencephalic banking capacity seems to be unlimited, and abnormal fixed deposits are never formed. At confinement she is suddenly deprived of hCG, and her diencephalic fat center reverts to its normal capacity. It is only then that the abnormally accumulated fat is locked away again in a fixed deposit. From that moment on she is again suffering from obesity and is subject to all its consequences. Pregnancy seems to be the only normal human condition in which the diencephalic fat banking capacity is unlimited. It is only during pregnancy that fixed fat deposits can be transferred back into the normal current account and freely drawn upon to make up for any nutritional deficit. During pregnancy, every ounce of reserve fat is placed at the disposal of the growing fetus. Were this not so, an obese woman, whose normal reserves are already depleted, would have the greatest difficulties in bringing her pregnancy to full term. There is considerable evidence to suggest that it is the hCG produced in large quantities in the placenta which brings about this diencephalic change. Though we may be able to increase the diencephalic fat banking capacity by injecting hCG, this does not in itself affect the weight, just as transferring monetary funds from a fixed deposit into a current account does not make a man any poorer. To become poorer, it is also necessary that he freely spends the money which thus becomes available. In pregnancy the needs of the growing embryo take care of this to some extent, but in the treatment of obesity there is no embryo, and so a very severe dietary restriction must take its place for the duration of treatment. Only when the fat which is in transit under the effect of hCG is actually consumed can more fat be withdrawn from the fixed deposits. In pregnancy it would be most undesirable if the fetus were offered ample food only when there is a high influx from the intestinal tract. Ideal nutritional conditions for the fetus can only be achieved when the mother's blood is continually saturated with food, regardless of whether she eats or not, as otherwise a period of starvation might hamper the steady growth of the embryo. It seems that hCG brings about this continual saturation of the blood, which is the reason why obese patients under treatment with hCG never feel hungry in spite of their drastically reduced food intake. The nature of human chorionic gonadotropin. hCG is never found in the human body except during pregnancy and in those rare cases in which a residue of placental tissue continues to grow in the womb in what is known as a chorionic epithelioma. It is never found in the male. The human type of chorionic gonadotropin is found only during the pregnancy of women and the great apes. It is produced in enormous quantities, so that during certain phases of her pregnancy a woman may excrete as much as 1 million international units per day in her urine, enough to render 1 million infantile rats precociously mature. Other mammals make use of a different hormone, which can be extracted from their blood serum but not from their urine. Their placenta differs in this and other respects from that of man and the great apes. This animal chorionic gonadotropin is much less rapidly broken down in the human body than hCG, and it is also less suitable for the treatment of obesity. As often happens in medicine, much confusion has been caused by giving hCG its name before its true mode of action was understood. It has been explained that gonadotrophin literally means a sex gland-directed substance or hormone, and this is quite misleading. It dates from the early days when it was first found that HCG is able to render infantile sex glands mature, whereby it was entirely overlooked that it has no stimulating effect whatsoever on normally developed and normally functioning sex glands. No amount of HCG is ever able to increase a normal sex function. It can only improve an abnormal one and in the young hasten the onset of puberty. However, this is no direct effect. HCG acts exclusively at a diencephalic level and there brings about a considerable increase in the functional capacity of all those centers which are working at maximum capacity. The real gonadotrophins. Two hormones known in the female as follicle-stimulating hormone, FSH, and corpus luteum stimulating hormone, LSH, are secreted by the anterior lobe of the pituitary gland. These hormones are real gonadotropins because they directly govern the function of the ovaries. The anterior pituitary is in turn governed by the diencephalon, and so when there is an ovarian deficiency the diencephalic center concerned is hard put to correct matters by increasing the secretion from the anterior pituitary of FSH or LSH, as the case may be. When sexual deficiency is clinically present, this is a sign that the diencephalic center concerned is unable, in spite of maximal exertion, to cope with the demand for anterior pituitary stimulation. When then the administration of HCG increases the functional capacity of the diencephalon, all demands can be fully satisfied and the sex deficiency is corrected. That this is the true mechanism underlying the presumed gonadotrophic action of HCG is confirmed by the fact that when the pituitary gland of infantile rats is removed before they are given HCG, the latter has no effect on their sex glands. HCG cannot therefore have a direct sex gland stimulating action like that of the anterior pituitary gonadotrophins, as FSH and LSH are justly called. The latter are entirely different substances from that which can be extracted from pregnancy urine and which, unfortunately, is called chorionic gonadotrophin. It would be no more clumsy, and certainly far more appropriate, if HCG were henceforth called chorionic diencephalotrophin.